Dr. Namita Arora. She is our beloved teacher and we have been groomed under her guidance. Madam is Professor of Anesthesia in Atal Bihari Vajpayee Institute of Medical Sciences and RM Hospital. Her area of interest are difficult airway, anesthesia, and ATLS training. The next examination is Dr. Neha Gupta. She is Associate Professor in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. Her area of interest are pediatric anesthesia, BLS and ATLS training, and airway management. Over to you, ma'am.
Thank you, Namita. Good morning, ma'am.
Thank you, Namita. Good morning. Is Dr. Gauri online?
Yes, ma'am.
Okay, good morning, Gauri.
Good morning, ma'am.
So are you ready? Shall we start?
Yes, ma'am.
Okay, so can you pick up this ampule for us, Gauri? Okay, just describe it.
Ma'am, this is a lyophilized
Can you hear me, Gauri?
Of 4 milligrams. Yes, ma'am.
Okay, start. Just describe this ampule.
Yes, ma'am. Ma'am, this is an ampule of 4 milligram of vecuronium bromide drug. It is in the form of a lyophilized powder. The expiry date of this drug is November 2023.
Okay, so what class of drugs does it belong to?
Ma'am, it is a non-depolarizing neuromuscular blocker.
Okay, so what is the mechanism of action?
Ma'am, non-depolarizing neuromuscular blockers are competitive antagonists at the nicotinic type of acetylcholine receptors. They compete with acetylcholine and bind at the post-junctional nicotinic type of acetylcholine receptors, which prevents acetylcholine from binding, and neuromuscular transmission does not take place and results in muscle paralysis.
Okay, so they act as competitive antagonists at the post-junctional acetylcholine receptors. Very good. So how can we classify muscle relaxants for it?
Ma'am, muscle relaxants can be classified into two, depolarizing muscle relaxants and non-depolarizing muscle relaxants. Non-depolarizing muscle relaxants can again be classified on the basis of their structure and on the basis of time of action. On the basis of structure, they can be divided into aminosteroidal, which includes vecuronium, rocuronium, and pancuronium. Another classification is benzyl isoquinolenones, which consists of mevacurium, atracurium, and cisatracurium. Based on the time of action, they can be short-acting, intermediate-acting, and long-acting. Short-acting includes mevacurium, intermediate-acting include atracurium, cisatracurium, vecuronium, and rocuronium, and long-acting includes pancuronium.
Yes, very good.
Depolarizing neuromuscular blockers include succinylcholine.
Yeah. So coming back to vecuronium, so it's a non-depolarizing muscle relaxant belonging to aminosteroid groups with intermediate duration of action. Okay. So what is the intubating dose of vecuronium?
Ma'am, 0.08 to 0.1 milligram per kg body weight.
And onset of action?
3 minutes.
And duration is, as you said, intermediate acting. So the duration would be?
Half an hour to 40 minutes, ma'am.
45 minutes. Okay, good. So, Gauri, how is vecuronium metabolized and excreted in the body?
Ma'am, vecuronium is mainly metabolized through the hepatic pathway since it is a liposoluble drug. 20% of excretion also takes place via urine through the renal pathway.
Main route of metabolism
mainly
is,
it is hepatic.
Main route of metabolism is the liver. And how about excretion?
Ma'am, excreted also, ma'am, about 20% is excreted in urine. Rest of it is excreted in the bile salts and enters the hepatobiliary circulation.
Okay. For metabolism and excretion. So, metabolism action both is high. So, if you have deranged liver function test, vacuronium should be avoided.
Any side effects of vacuronium?
Any
No,
side
ma'am.
effect?
As such, it is a very cardiostable drug compared to a long-acting non-depolarizing neuromuscular blocker like pancuronium, which had two side effects. That is, it was vagolytic, it caused tachycardia, and also that it was very long-acting. So, although it was more potent than vacuronium,
So the immediate can say the yes, unlike immediate predecessor that pancuronium, which was highly vagolytic and caused tachycardia, vacuronium is comparatively very cardiostable. It doesn't cause any tachycardia or hypertension. Okay. So
yes,
can you just pick up this vial and describe it?
Ma'am, this is a multi-dose vial
Just
of
show the vial.
rocuronium bromide with a concentration of 10 milligram per ml. The expiry date of this drug is November 2022.
Okay, so can you tell us about the structure and classification of rocuronium?
Ma'am, rocuronium is also a monoquaternary ammonium compound. It is a non-depolarizing neuromuscular blocker. It is also intermediate acting, and it is an aminosteroidal drug.
And what about its dosage and duration?
Ma'am, the standout quality about rocuronium is that it has a dose-dependent onset of action. The dose of rocuronium varies from 0.6 milligram per kg to 1.2 milligram per kg. When a dose of 0.6 milligram per kg is given, the onset of action starts at 3 minutes. However, when a dose of 1.2 milligram per kg is given, the onset of action starts in 60 seconds. This can be put to use in a rapid sequence induction, which is why this dose-dependent onset of action of rocuronium is very useful to us.
Yes, very good. So basically, that is a peculiar feature of rocuronium, that its onset is dependent on the dosage, and in a dose of 1.2 milligram per kg, the onset is as fast as 60 seconds, can be used for sequence induction. Very good. How is it metabolized and excreted?
Ma'am, this is also mainly hepatobiliary metabolism takes place for rocuronium. So we should avoid using it in patients with deranged LFTs.
Yes. So similar to vacuronium, even rocuronium is highly dependent on liver, its metabolism and excretion. Very good. So suppose you have a patient has a liver or renal derangement. So what is your drug or the relaxant of choice in such patients?
Ma'am, the drug of choice in patients with deranged LFTs and KFT is another non-depolarizing neuromuscular blocker known as APPEC2023 DAY6 This is a vial of APPEC2023 DAY6. It is a 2.5 milligram milliliter ampule of 10 milligram per ml of APPEC2023 bisylate drug.
Yes. So what makes it the drug of choice in such situations? Why is it so?
Ma'am, actually the metabolism of APPEC2023 takes place via the Hoffman elimination, which is a non-enzymatic chemical degradation. It is pH and temperature dependent. Another way of metabolism is ester hydrolysis. So these two processes, they take place in plasma, and that is why it can be used in patients who have deranged LFTs and KFTs.
Okay. Any side effects associated with APPEC2023 DAY6?
Yes, ma'am. Ma'am, APPEC2023 causes histamine release. So it is contraindicated in patients of bronchial asthma. However, we can reduce this side effect by giving a slow injection of APPEC2023 or by giving antihistaminic drugs. Another side effect is that its metabolite known as laudanocin. It is a CNS stimulant and decreases the seizure threshold and is mainly excreted in bile salt. So one should, in cases of patients with biliary obstruction, we can avoid giving this drug to them.
Yes, in patients who have deranged liver function, the excretion of laudanocin can become an issue, and it can accumulate and can cause a
Yes, ma'am.
decrease in threshold for seizures. That's right. How about the dose and onset of action of atracurium?
Ma'am, dose is 0.5 milligram per ml. Ma'am, onset of
kg.
action is milligram per kg. Onset of action is again, ma'am, 3 minutes, and duration of action is about half an hour to 40 minutes.
It's again an intermediate acting agent.
Yes, ma'am.
So is there any other drug which doesn't have side effects similar to atracurium, like histamine release and laudanum accumulation?
Yes, ma'am. Ma'am, cis-S stereoisomer of atracurium, known as cis-atracurium, can be used to avoid side effects of histamine release.
Yes, it is very much available in many setups, and the histamine release, which is seen with atracurium, is not seen with cis-atracurium. Okay, good.
Yes, ma'am.
Ma'am, would you like to take over?
Okay, Gauri, can you hear me? You can hear me?
Ma'am, yes, ma'am.
Yeah. So can you pick up that brown color, dark colored ampule?
Yes, ma'am.
Yeah. What drug?
Ma'am, ma'am, this is a 2 ml ampule of 50 milligram per ml of succinylcholine drug.
Okay, it's a chloride.
It's a chloride, ma'am, succinylcholine. Yes, ma'am. Succinylcholine chloride drug.
Yeah, and whenever you whenever you pick up the ampule, and in the exam when you describe, you should always also look at the expiry
Date
date,
of expiry.
right?
Ma'am, its date of expiry is November 2023.
Yes, good. And what kind of drug is it?
Ma'am, it is a depolarizing neuromuscular blocker.
Okay, what do you understand by depolarizing?
Ma'am, depolarizing neuromuscular blockers, they have an affinity for the acetylcholine receptors. They act as an agonist on the receptor, where they attach and cause persistent depolarization of the motor end plate. But they are not metabolized by acetylcholine, which leads to persistent depolarization of the motor end plate, and they cause muscle relaxation.
Yes. So normally what acetylcholine does, it reacts to the receptors and is then immediately hydrolyzed by cholinesterase.
Acetylcholine is
This does not happen with the succinylcholine.
succinylcholine.
So what is the dose in which we use succinylcholine?
Ma'am, succinylcholine is used in the dose of 1 to 1.5 milligram per kg body weight.
And the onset of action is in
Ma'am, 60 seconds.
60 seconds. So it's a very rapidly acting neuromuscular agent blocker, and it gives a excellent intubating conditions. And the effect lasts for what duration?
Ma'am, 6 to 10 minutes.
6 to 10 minutes. Very good. And have you ever used succinylcholine?
Yes, ma'am. Succinylcholine, since it is a very rapid acting neuromuscular blocker, it can be used for rapid sequence induction. It can be used in the management of difficult intubation. It can also be used in electroconvulsive therapy patients in psychiatry. And it can also be used in the management of post-extubation laryngospasm.
Very good. Very good. So multiple uses and very typical uses. It's so-called an anesthetist friend because it provides excellent intubating conditions in rapid sequence induction, and also for management of difficult intubation because the effect is short lasting. As a result, if you find it difficult to intubate, the patient's spontaneous respiration is restored on its own without requiring any reversal. And so patients, even if we fail to intubate, patient starts spontaneous breathing on his own, right?
Yes, yes, ma'am.
So what are its side effects? It's a very good drug, but must be having some side effects.
Ma'am, the first and the foremost most important side effect is hyperkalemia. It causes a rise of 0.3 to 0.5 millimole per liter increase in the potassium levels in blood.
Okay. So you think this is troublesome, this side effect for us in certain conditions?
Yes, ma'am. Ma'am, it increases risk in burns patients, patients with muscular dystrophy, hemiplegia, spinal cord transections. In such patients, there is increase in the extrajunctional receptors of acetylcholine, which causes even more potassium release. So it can have varying clinical features of hyperkalemia in such patients, we can see.
So any burn patient who comes with acute burns to emergency, can we use succinylcholine?
Yes, ma'am. Yes, ma'am. So, ma'am, we can use succinylcholine either in a period of less than 48 hours or after a span of 2 years. So, less than 48 hours and after 2 years, we can use succinylcholine in such patients, in patients of burns.
Yes, very good. Because it takes time initially for the extrajunctional receptors to form, and then we can. Okay, because you are like, any other side effect?
Ma'am, it also causes increase in the intraocular pressure, intracranial pressure, intragastric pressure. It causes stimulation of the autonomic ganglion, which causes tachycardia, hypertension, arrhythmia. Cardiovascular side effects include, junctional arrhythmias and bradycardia.
Okay, what about
It can
increase in the intraocular pressure? Any specific type of eye injuries where it should not be used?
Ma'am, in open globe injuries or penetrating eye injuries, we must avoid because this can cause extrusion of the intraocular contents.
Very nice. So if there is increase in the intraocular pressure, which if there is a dangerous increase, then it can cause extrusion. But can you, okay, you were talking about cardiovascular effect and any other side effects?
Ma'am, it also causes myalgia, most commonly seen in young patients or in very short duration of surgeries. And it can also cause masseter spasm in patients of impending malignant hypothermia.
Yes, so it can cause, you can't say it causes masseter spasm in patients of malignant hyperpyrexia, but yes, if there is a patient who reports or you notice masseter spasm after giving scoline, then this indicates a predisposition to possibility of malignant hyperpyrexia, especially if used in combination with inhalational agents like halothane, right? Okay. How is it metabolized?
Ma'am, it is metabolized by an enzyme called pseudocholinisterase, which is found in the plasma.
Yes. Any other, you were just talking to Dr. Neha, is there any other muscle relaxant which is metabolized by pseudocholinisterase?
Ma'am, a very short-acting non-depolarizing neuromuscular blocker known as mivacurium is also metabolized by pseudocholinisterase.
Very nice. Very good. Over to you, Dr. Neha. Maybe we can ask some questions on the reversal agents.
One thing more about succinylcholine. Gauri, can you tell us something about phase 2 blockade?
Ma'am, if we give an excess dose of succinylcholine over a short period of time, or if we keep on giving multiple doses of succinylcholine, then the depolarizing agent, it starts behaving like a non-depolarizing agent. And this can even not be reversed by anti-acetylcholinesterase enzyme. So this is known as phase 2 block.
Yes, so it's important to know that it occurs when we give either repeated doses of succinylcholine or give it in large amount. Which mimics a block due to non-depolarizing muscle relaxant, but it is not responsive to our usual reversal agents. And it's because of modulation of your pre and post junctional receptors.
Yes, ma'am.
And one thing more, what do you mean by priming and pre-curarization?
Ma'am, in priming, usually give 1/10 of the dose of non-depolarizing neuromuscular blocker. We wait for a minute and then we administer the intubating dose of the non-depolarizing neuromuscular blocker.
How much time do we wait for after giving the priming dose? No, it's 3 minutes. We have to wait for around 3 minutes. You give 1/10 of the intubating dose, wait for around 3 minutes, and then give a second full intubating dose. So how does How does it help?
Ma'am, I can't hear you, ma'am.
Neha, you can tell how it helps.
So it helps in decreasing the onset.
So it helps in decreasing the onset. Normal of onset of depolarizing is around threats. It helps decreasing the onset by around 60 to 90. Okay. And what is pre-curization?
Ma'am, when we prime with a depolarizing agent like succinylcholine, then it is known as pre-curization.
No, you again give 1 dose of your non-depolarizing agent, and then after 3 minutes, a full dose of succinylcholine. Right? So giving a non-depolarizing agent before the dose of depolarizing. And what is the advantage?
Ma'am, again, it decreases the intubating
It
dose
helps
of
in no, it's in interacting the increased intraocular or intracranial pressures due to succinylcholine and also the fasciculations. So all the side effects of succinylcholine that we discussed, they can be minimized if 1/10 of non-depolarizing agent is given prior to succinylcholine. Okay.
Yes, ma'am.
So can you pick this ampule
Yes, ma'am.
and show it to us? Oh, describe.
Ma'am, this is a 1 milliliter ampule of 0.5 milligram per ml of neostigmine methyl sulfate. It has the expiry date of February 2025.
Okay, so which class of drug is it?
Ma'am, it is used as a reversal agent. It belongs to the class of acetylcholinesterase inhibitor. It reverses the action of neuromuscular blockers by inhibiting acetylcholinesterase and increases the concentration of acetylcholine in the synaptic cleft. This acetylcholine, it displaces the residual neuromuscular blockade drug from the receptor and can cause muscle contraction.
It reverses.
Ma'am,
Do you give it by itself or you combine it with some?
Ma'am, we usually
drug.
co-administer neostigmine with glycopyrrolate, 0.01 milligram per kg. So, ma'am, activation of neuromuscular receptors by administering neostigmine, it causes cholinergic response across the body. This may result in bradycardia, hypotension, bronchoconstriction, and increased secretions. Glycopyrrolate is an anti-muscarinic drug. So it causes decrease in these cholinergic effects of administering neostigmine.
So what is the dose?
Ma'am, dose of neostigmine is 0.05 milligram per kg intravenously, given intravenously, and dose of glycopyrrolate is 0.01 milligram per kg body weight.
Can you hear me, Gauri?
No, ma'am.
Hello, can you hear me?
Ma'am, I can hear Namita Arora, ma'am.
Okay. What is the dose of glycopyrrolate?
Ma'am, 0.01 milligram per kg.
Can you hear me, Gauri?
Yes, ma'am. Yes, ma'am.
Okay, so your dose of neostigmine is 0.05 milligram per kg and glycopyrrolate in a dose of 0.01 milligram per kg. And you add glycopyrrolate to counteract the side effects which are caused by neostigmine. Any other agent which can use in glycopyrrolate? Any other agent?
Ma'am, we can use atropine, but we prefer not to use atropine because the onset action of glycopyrrolate and neostigmine are very similar. So they can act simultaneously and provide better muscle.
And another reason is an atropine being a stronger antimuscarinic agent would cause a greater tachycardia. We do not want
Yes,
that. So glycopyrrolate and plus matches your onset with neostigmine. So that's why as a reversal agent, both of them are added. Okay. So one side effect of neostigmine, as we have discussed, are the muscarinic acetylcholinergic effects. Any other
Yes, ma'am.
limitation of using these anticholinesterases?
Ma'am, anticholinesterase have a property of sealing effect. So, ma'am, they can only be used to reverse residual neuromuscular blockades. They cannot be used for. They are not effective in blocking or reversing deep blocks, deep neuromuscular blocks, because of this sealing effect.
Very good. So whenever, yes, so whenever there is profound or deep neuromuscular blockade, your anticholinesterases won't be effective because there's sealing effect as to how much they can insert acetylcholine in the cleft, and they are just effective in reversing the residual neuromuscular blockade.
Yes, ma'am.
So suppose you are using rocuronium or in a patient and the patient is deep, you just given a top up of the relaxant and you immediately want to reverse the patient. So do you have in this scenario, neostigmine will help, right? So
Yes,
do
ma'am.
any other drug which can help you in such a situation?
Yes, ma'am. Ma'am, we have a drug known as Sugamadex. It is a modified cyclodextrin which has a lipophilic core and a hydrophilic periphery. So what happens is that steroidal drugs like rocuronium and vecuronium, they are encapsulated in the lipophilic core of the drug, and it becomes a water-soluble compound which can be excreted in urine. So this can cause rapid reversal and can be used in deep blocks. One more advantage of this is that it does not have any muscarinic side effects of acetylcholinesterase inhibitor drugs.
And the only limitation is it is only effective for your steroidal compounds like
Steroidal drugs like rocuronium and vecuronium.
Yes. In case you are using atracurium, so it's not useful. But anyways, in atracurium, reversal is not much of an issue. Right.
Yes, ma'am.
Okay. What is the dose of Sugamadex?
Ma'am, to reverse moderate to shallow plane of block, ma'am, 2 to 4 milligram per kg can be administered. But in case a deep plane of block, which is given with rocuronium, we can administer 16 milligram per kg body weight of Sugamadex to the patient.
Ma'am, you would like to add anything?
That's it. I think Dr. Gauri answered very well, and it's important. It's really an advice to everyone that you need to know the basic drugs and pick up the drug. And whenever you have to say the contents of the drug, please make sure that you read the full name of the drug along with the salt. Okay? And you can easily read the strength of the ampule or vial. It's written how many milligram in each ml. Okay, that is not something if you can look at and answer. Okay, and I think you've done very well, Gauri.
Thank you, ma'am.
Thanks, Neha. I think we can conclude here.
Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you, Namita, ma'am. Thank you, Neha, ma'am.
Thank you so much, Namita ma'am and Neha. So before proceeding for the lunch, I would like to announce the winner of quiz of yesterday, Dr. Aarti Kumari. She is from BMMC Sabdajan. Congratulations. As a reward, we will be reimbursing your registration fees. And for day 4 also, we did not announce the winner of the quiz. The winner is Sainath Viranki from AIMS. Congratulations to you, and similarly, we'll reward you with the reversal of registration fees. And now we'll break for the lunch and meet sharp at 1:30. Thank you. We'll have a lecture before proceeding for the lunch. Sorry for this glitch. We'll be proceeding with the lecture. I would like to invite our chairperson. I would like to welcome Dr. Neja Banerjee. She is Professor Anesthesia in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. The area of interest are critical care and neurosurgery. Madam is instructor of ATLS and CCLS. Ma'am, I would like to invite you. Neja ma'am, are you there? Neja ma'am, are you there?
No, ma'am. Since it's not in Zoom right now.
Okay. Just give me a minute. I'll just coordinate with ma'am. Yeah, now Neja ma'am is with us. Gurmeet, kindly please display the CV again. I would like to invite Dr. Neja Banerjee. Madam is Professor Anesthesia in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. Her area of interest are critical care and neurosurgery. Madam instructor for ATLS and CCLS. Ma'am, I'll hand over the proceeding to you. Ma'am, ma'am, you are mute. Yes, ma'am. Now we can hear you. Welcome, ma'am.